These are not routinely recommended, but if you really need them, you have to do a risk versus benefit ratio when you do that. So as they're talking to the patient, with the patient about what's good, what's not. A lot of this will mostly be due to either them traveling to some place that has some type of endemic disease or there's some sort of outbreak. Okay. Standard, there's two things. You've got adverse reactions and you've got adverse events. Okay. Adverse reactions are a specific type of adverse event. Okay. Generally, it's a health problem caused by the vaccine. Usually a local or systemic issue. Okay. Versus the event. The event is a little bit different because the event can cover any medical occurrence after the vaccine, even if it's not related to the vaccine. Okay? So the reaction is based against the vaccine. The event can be based against anything. It may or may not even be associated with the vaccine. But that's the definition for the event. Now, we have what we call the VARS system within the U.S., Vaccine Adverse Reaction Event System, reporting system. And what that's supposed to do, it's run by the CDC and the FDA together, and what it's supposed to do is it's supposed to monitor the safety of the vaccines, right? Everybody has access to this thing, whether it's a parent, whether it's a patient, whether it's a provider, whether it's a tech, whether it's a pharmacist. Anybody has access to VARS so that they can report any adverse events or adverse reaction to a vaccine. And what those guys do is they'll take it and they'll look against whatever the standard reactions are. If it's something that's different than the standard reaction, then they may start to investigate so that they can figure out if it's something different that has not been known yet. Okay. And all those guys will do is just collect the data on the adverse events and reactions, and they'll just investigate. Okay. Here's some local inflammatory hypersensitivity reactions. Right? Wherever you get stuck, usually that's where it's going to swell up. It might be a little bit sore. Usually it goes away within a week or so. Right? Does that look right?
Pretty red.
This is from an anthrax patient. Okay. No, that doesn't look right. Okay. So you have to be careful. You have to make sure you put it in the right place. Okay. You have to make sure that you use appropriate infectious control techniques. Okay. In this case, I think we put it in the wrong spot. Okay. There's some cellulitis, right? Erythema, pain, swelling. If you're not quite sure, this is where they gave it to him, and you can see a red streak going over his arm. Okay. It's usually the big giveaway in this case. And usually you won't compress it in antibiotics, usually what we give them. Okay. So shoulder injury related to vaccine administration, or acronym is SERVA. This can be prevented very easily by putting it in the right place. Okay? If you put the vaccine that's going to go into the delta into the right place, then you won't have this issue. What happens is folks go too high on the shoulder, and instead of coming in at a 90-degree angle, they come in at a 45-degree angle, like the picture has there at the bottom, and they end up going to the shoulder joint. Okay? Because it's in the joint, it's going to cause some serious problems. Okay? You're going to end up needing rest, you're going to end up needing anti-inflammatory, you're going to end up needing physical therapy. It's going to hurt for a long time. This stuff usually starts bothering you about 48 hours after you do the injection. So you have to be very careful with that. The appropriate way to do it is you have your acromion, take 2 fingers, what we call 2-finger breaths, stick it right at the bottom of that acromion and down from there. Okay? So once you do that, anything below there will be a safe place for the injection into the deltoid. But just remember, the needle needs to be 90 degrees, not angled. It needs to be 90 degrees. Big things to remember. One of the questions you may want to ask is, have they ever had any complications with an injection into the shoulder? Because if they've had this, they will remember and they will tell you, hey, I have had a problem because somebody's injected me improperly into that shoulder. Usually we don't like to give injections back into that shoulder again because there's just a propensity to possibly get it infected again, which is what we don't. So usually we'll use the other shoulder, we'll use a different body part. Okay? That area remains vulnerable for injury. So we try not to use that same shoulder. If this happens, this goes into that VAERS reporting system. Because this can fall under the vaccine injury compensation program that the U.S. has, and we'll talk about that here in a little bit. All right, here's some hives, raised, itchy bumps, can change any area of the body. All right, this can either be an adverse reaction or an adverse event, depending upon what caused the problem. Right? If it was the vaccine, it could be a reaction. If it wasn't the vaccine and they have maybe seasonal allergies or they ran into something that annoyed their skin, it would be an adverse reaction. But either way you look at it, this would still be something that you would submit in the VAERS system. Here are some neurologic issues. I'll probably know these. Right? We have acute disseminated encephalomyelitis, transverse myelitis, Guillain-Barré syndrome, brachial plexus neuritis. Right? These are all possibilities of what can occur status post some vaccines. My suggestion to you would be whatever vaccine you're looking at giving, just take a quick look, look at what the contraindications are, look at what some of the possibilities are, and in this case, we'll use Guillain-Barré as an example, right? That's a autoimmune neurologic disorder, right? Starts at your feet, works its way up, right? The most common thing that we usually give every single year is influenza. If you read influenza, that little insert, it'll tell you, hey, if someone has had a history of Guillain-Barré syndrome, you probably should give it to them, or you should be very cautious in giving it to them, where there would be some place where you can kind of take care of it if anything happens. This stuff doesn't usually kick in pretty quickly. It usually takes a couple of hours to kick in. But remember, some of these things are adverse events, and any of these things happen, you need to report them to the NAR system. Febrile seizures. And here it tells you it's common in little kids, common in toddlers. Depending upon how many vaccines you're giving kids, is the possibility of them actually having febrile seizures. So you kind of have to be careful with that. But if they have had febrile seizures in the past, if it is family history of it, you really need to keep that in mind when you're giving them vaccines. Or especially if you're giving them multiple vaccines where some of the side effects are impossible fevers. It's very vaccine dependent. The more common one would be MMR for kids that cause some of these febrile seizures. Alright, other adverse effects that we still report in VAERS system would be syncope or vasovagal syncope. This is one of the reasons why usually we'll have the patient sitting down. Sometimes you'll see people standing up getting their shots. The question you may want to ask them is like, hey, do you pass out when you get shots? Do you like shots? Because usually when they say no, they don't like shots, usually we'll just sit down because I'm not quite sure if they're going to pass out when they get it. And And there's some symptoms of the vasovagal. I probably know those. Okay, pale coloring, lightheaded, low blood pressure, slow heart rate, diffuse sweating, complaining of nausea, and then they usually just pass out. Okay. And then hyperventilation, tingling sensation, and hand and feet. Really, what you got to do is just calm them down. A lot of times, if they hyperventilate, they may also pass out. Another reason why we usually have them sit down, because if they stand up and they do it and they pass out, they smash their head on the ground, right? And you don't want to have to do that, because that is a problem that you just caused that patient, and more work for you to have to do. National Childhood Vaccine Injury Act of 1986 led to the creation of ours. Yes, ma'am?
So, just a question about figures, because the sense I've always gotten is that it's not taken very seriously. I've never heard of them actually investigating the reports, and when it's run by the CDC and the FDA, they both fall under sovereign immunity, so they cannot be held accountable for adverse drug reactions. Who's actually taking this seriously?
Everybody hear that? No? Okay. She said that she's heard theirs is not taken seriously. She said CDC and FDA fall under sovereignty, and what does it matter that you report it varies? You are partially correct. You are partially correct. It does fall under CDC and FDA. It is a co-management thing. They don't necessarily fall under sovereignty. Some of the stuff that we're about to talk about actually is what's going to cover what we just talked about. Right? The question really comes down to, does it matter that I report? Because who really cares? Because I never see an investigation. And you don't see doesn't mean that's not happening in the background. All right? Because, and here's the key, because some of this stuff, like now the National Childhood Vaccine Injury also led to some other things. For the one that was done in 1980, we'll get to it here in a bit. That one creates two other entities that review all that work that they do in the background. If you have it documented in the VAERS system, you can demonstrate that in the court of law for compensation from the government. Okay? So back in the 70s, they were having a lot of problems with vaccines. Not all, specifically tetanus, diphtheria, pertussis. That was the big one that they were having problems with. So what happened was a bunch of lawyers got together. They were trying to sue all the pharmaceutical companies. So the pharmaceutical companies, in response, were like, you know what, this is too much of a hassle. And we're trying to help the population, not hinder the population. So all the manufacturers stopped making tetanus, diphtheria, pertussis. The government, public health, realized that that was a bad thing. We started having increases in the public health sector of more of those issues. So they ended up developing two specific organizations that would take some of this information and use it, right, in order to be able to compensate people, but it would be no fault to the pharmaceutical companies. Okay. Do I agree with that? No, I do not. I think pharmaceutical companies should be held accountable to some of these things, but again, personal opinion is different than what actually occurs. So is it important that we report? It is, especially if they're civilians, okay? Because they're going to look for compensation if it affects their life, if it messed up their body in some way, shape, or form that wasn't known before, right? Pain and suffering, if they couldn't go to work, right? There's a lot of compensation that goes behind that. So yes, it is still important for us to document, because they're going to take that piece and they're going to use it as part of their litigation. So this was formed in the National Childhood Vaccine Injury Act was 1986, which really was spurred by that issue in the 1970s. From there, they developed the bars, and here it just tells you new and rare events. So my personal opinion, not part of the test, right, is to understand where things come from and how they get them tested. Right? This goes back to that. What I usually do as new stuff comes out, I let it come out to the mass population without pushing it to my patients. And the reason why I do that is because I want to see what it's going to look like when it gets distributed to the mass population. That's not what the studies usually show. So once it's been out, distributed through the mass population, you can truly see what the results are going to be. And from there, you can make a better educated decision as whether or not you think you should or shouldn't push or educate your patient with that new thing. Okay? Once you guys become providers, you guys will choose how you guys choose to take care of patients. That'll be on you. That is what I do. And I learned that from when I was a baby PA starting off with the COX-2 inhibitors. That's when they first came out on the market. There was like 4 of them. Right? And the only one that's left is Celebrex. Okay? So gotta be careful with what you give. Right? There's VARs you can submit. They've got a whole bunch of different ways to submit. You got a website, fax, mail, telephone number, email. Okay. So this is a collaboration between the CDC and 8 managed care organizations across the country. Okay. They use what we call vaccine safety data link. And what they did was they collaborated on this project and they looked at large U.S. healthcare organizations across the U.S. This is one of the biggest I don't call it studies, but projects that they did that involved over 7 million Americans going through their electronic medical records and seeing how they did status post vaccines or vaccination. Okay? And this is real-time data that they were gathering. So what they were trying to do is that they were trying to link or Uracil with some sort of medical problem, specifically autism. And over the 7 million American medical records that they reviewed, they didn't find any links to autism.
What year was that study?
That is an ongoing thing that they just did, I want to say like 5 years ago. This is the get back number. You can call this number and they can talk to you about vaccines if you have questions about vaccines. So here's the 2 specific injury compensation programs that came out of the litigation stuff from the 1970s. And was part of that National Childhood Act. You have your National Vaccine Injury Compensation Program. As you can see, the very first bullet says no fault. Okay? So that puts no fault on the pharmaceutical company. That one was specifically established right after the 1986 National Childhood Vaccine Injury Act was made. And it's basically a federal program. The federal program, the federal government decided to take it over in order to be able to compensate folks who get injured by any type of vaccines. And if it causes them any injury, causes them any liability. responsibility. They'll take the fault instead of the manufacturer taking the fault. That one is run by the U.S. Health Resources and Service Administration and the government. And then you have your countermeasure injury compensation program, public health emergency, pandemic issues, more so, but this is still a U.S. federal program that compensates for serious injuries or death caused by certain medical countermeasures, such as vaccines, drugs, devices. So it's a whole bunch of other things, not just for vaccines, particularly when there's a public health emergency. Right? So we'll use COVID as an example. They came out with those mRNA vaccines because it was a public health emergency. If anyone were to have serious problems due to an mRNA vaccine, that is one of the compensatory measures that you can look for to use. Okay. This one is run by the health secretary, and they're the ones that actually make the final determination for that one. For the CCIP, you have 3 years to apply for it. Back to vaccines, amongst the most cost-effective medical intervention. Remember, we're talking public health, so protection-wise, impacts are global, right? Public health, individual health, economies, global developments. People are living longer. There's been quite a bit of benefit that we've received from vaccines. Big ones, specifically smallpox, we've been able to almost eradicate. At least the World Health Organization has said we've eradicated smallpox back in 1980. We've almost eradicated polio. We have certain countries like Afghanistan, Pakistan that still have some polio left. But all the standard childhood diseases that we would generally have, or people would generally die for, kids like MMR, diphtheria, tetanus, or whooping cough, Hep B. These things have helped tremendously. Anybody have any questions? This next one's a little bit easier. This is occupational health. Here's some regulations and rules we're going to talk about. Here's our mission, right? Promote health and safety in the workplace, in the community. Keyword, occupational health, workplace, community, okay? Public health, population, community. All right. Just like, do the difference there, right? Focuses on education, regarding hazards and medical surveillance with the occupational environment. These are the guys that are going to fit test you for masks when you start working in the hospital. And you are going to need to be fit tested for N95 mask in order to work in a hospital. Okay? These are the guys that do that stuff. They want to make sure that you stay safe. Okay, here's some goals that they do. Sure workers are physically and mentally capable of doing their duties. They've got a whole bunch of different things, right? Their big deal is to prevent work hazards in the workplace. Right? They are there to do some health surveillance for you. If you think there's something going on in your little job, in your area where you work, they can come out and do some surveillance and monitoring and make sure that it is safe. That includes the air that you breathe to the ergonomics that you're working in. Okay? These are the guys that can get you those ergonomic chairs and ergonomic keyboards and all that other stuff. They're the ones that run the safety programs wherever you're going to go, whether it be a clinic or a hospital. They These are the guys that do those annual inspections. And another piece of the job that they don't normally talk about much is mental health well-being. That is a piece that they don't really talk about. That bottom one there says prevent decrements in combat readiness in the military. You know, we try to be as safe as we can. Right? That doesn't necessarily mean that we don't. Right? We still get hurt. We still have guys that get hurt when they go out to the field and start doing other stuff. But these guys try to do their best they can. That little reduce economic loss, right? If you have a healthy worker is a happy worker, hopefully, who can be a productive worker, in which case they'll be at work, in which case no loss of revenue for both the worker and for the institution that they're working for. Prime role, to protect soldiers, sailor, and airmen, protect DoD civilians, and MSF for public health. Real simple, because these guys right now, this role, we're talking about them working for us here on federal installations. If they're outside in the civilian sector, then they'll be worried about the population itself. And folks that work in every individual section of wherever they're covering. We want to make sure that we follow the laws and regulations. And there is a specific executive order, right, 1219-6, that covers this, that started this. Right? The main job that this was started for was to maintain healthy workforce, right? Maintain productivity. OSHA, do you guys know what OSHA is? The Occupational Safety and Health Act. That was started because of this. We wanted to help workers to keep them healthy. Some organizations, right, not necessarily the military, or the civilian sector, want to try to keep their people healthy. As part of their occupational health safety plans, they pay for people to have gym memberships so that they can go to the gym. We have that here for free for the military, but in the civilian sector, it's not free. But some companies will pay for it because it's part of their occupational health program. Keep your person healthy, keep them more productive. Now, a lot of this stuff came about, I don't know, do you guys know who Upton Sinclair is?
Yes.
Okay. He was a writer. He was a writer back in the early 1900s. I believe it was 1905 or so, when he wrote a book called The Jungle. And what he wanted to bring out to light was he spent 7 weeks undercover working in a meat packing plant, trying to collect data, trying to see how things actually worked, so that he can go and highlight all these things when he wrote his book. And what he had on that book was the working conditions and the health violations were unsanitary. Okay? And this is a meat packing place where all the meat that they were cutting and making was going out to the population. Okay? So he brought that out, he highlighted that. Once that book came out and the public started reading through it, it caused a public outcry of reform, not just for the meatpacking industry, but for worker safety overall and food safety overall. So that was a big deal back in the early 1900s for occupational health. So these are the laws and regulations. Occupational Safety and Health Act of 1970. That is, just remember this, that is the primary federal law governing occupational health. Okay. got that executive order 12196, 29 CFR Part 1960. Right? That one was made by the president. So the president just made the executive order. It goes out. OSHA, Occupational Safety and Health Act, or organization in this case, goes out and enforces it. So it's not the executive order that really does it. It's the Occupational Safety and Health Act that does it. And that's why it's the primary federal law governing occupational health. You got MPH. Okay. MPH is the research and recommendations section of OSHA. And then OSHA itself does the regulation and enforcement. So this one has two entities as well. It's a suspicion that really should be based on the job that you're doing. Right? For occupational to go, occupational health to come and go and try to help you. Try to stay safe. Okay? That right there may be a good reason for you to ask what the occupation is when you're doing your HPI, right? You're giving all that information as part of your marginal information. Ask them what your occupation is, because then you can kind of figure out if they're going to have any serious problems or hazards at work. Oh, actually, for this one right there, it says asthma dermatitis. I worked in a building a long time ago where a lot of the people were getting skin rashes, right? And over time, more and more people would say, yeah, I get a rash when I come to work, but then when I leave, I'm good. Right? It doesn't make sense to me. Right? So we called Occ Health, and they came down and did a sampling test, and they found mold in the air, which was what the cause of the skin rashes were for those people that were getting it. Which is why when they left, they were okay. But when they were at work, they weren't. Okay? So they'll come and they'll do all that stuff. You just gotta let them know you got something going on. And then they ended up cleaning all the HVAC system and all that other stuff. And then the people started getting out better, which was great. But again, that was an Occ Health thing. And you guys will be able to do the same thing. All right, just call Occ Health. Okay. Usually the military uses a bunch of internal programs. We have the Army Safety Program. Right? I'm sure the Navy and the Air Force have their own safety programs. But there are certain things that fall under Occ Health. Injuries and accidents fall under Occ Health. They'll come out and investigate. You have to do an SIR if it's bad. Noise. You got to get your hearing checked every year. Solvents, carbon monoxide, stuff that we have out in the motor pool. And then radiation. Part of that having to be checked every year if you're an X-ray tech. You walk around with a little dosimeter to see how much radiation you're actually being exposed to. That can cause a lot of different problems, right? That can cause cancer, that can cause infertility issues. So somebody needs to be able to track that. And these are the guys that usually track it. Okay. Tended to be a system of record for occupational hazard and surveillance. Have you guys heard of DOORS? Defense Occupational and Environmental Health Readiness System. That's the one where you do all your hearing. That's where all your hearing stuff goes into. That's where your vision stuff goes into. DOORS. Okay. So that's what they look at for your annual stuff to see if there's any serious issues with trends. Right? They take that data, they collect that data, they analyze that data, and they end up reporting that data. To make sure that we are staying healthy. Here are some jobs that require medical surveillance, right? So some folks have to be followed every year for medical surveillance just due to the things that they do, right? So welders are exposed to UV light, right? UV radiation for their eyes. Okay? they need to be checked every year. They get exposed to metal fumes, and their lungs need to be checked every year. So depending upon what your job is whether or not you end up having to do medical surveillance. Here it's got healthcare workers, right? What are we exposed to? Blood-borne pathogens, right? We're exposed to a whole bunch of different diseases. If you work with an HIV person, you're exposed to HIV. If you work with Hep B patients, you're exposed to Hep B patients. If you work with tuberculosis patients, you're exposed to TB, right? So if you have any of those issues, and you need to be followed to ensure that you do stay safe. So here's a whole bunch of different job series of folks that should be under medical surveillance. Your job-related medical surveillance, medical examinations. A lot of times we'll do pre-exams, and then we'll do periodic exams. There you do fitness for duty exams. AR 40-501 for the Army guys, standards of medical fitness. Your fitness for duty exam is in there. Okay. Here it gives you a bunch of other folks that work with chemical and biological stuff, extremely important. The Army has a smart book, DA PAM 611-21, I think. Don't quote me on that. But it lays out every single MOS that the Army does to include its requirements. And that is what Health uses to determine fitness for duty. That determines what Health uses to ensure that you can still do that particular AOC or MOS. And then they also try to help with treatment of occupational illnesses and injuries based on what the type it is. Here's some work-related physicals, initial and termination physicals for GS employees. Make sure that they're okay, especially if they're going to go overseas. There are specific criteria for government employees going overseas that we must meet. We can do annual medical surveillance for specific exposures. Here it's got civilian and active duty, and at the bottom there it's got CDL license. Right? And CDL is a commercial driver's license. That is run by the Department of Transportation in the civilian sector. Okay? We have to do annual exams on commercial drivers. We in the military, but UPAs can do that in the civilian sector. Okay? They must annually pass this, right? Because if they have cardiac issues, because they were finding truck drivers were having a lot of cardiac problems while they were driving, right? So if you're driving an 18-wheeler and you have a heart attack, that truck's going to run rampant someplace, right? And that's kind of what they were trying to get away from. So they're required to have that. Just like aviation is required to have their annual physicals as well. Okay. Some respiratory issues required for anybody wearing a respirator. Really depends on what you're doing, what your job is. For us as medical healthcare workers, you will be fit tested for an N95. These guys will do that for you. But one of the specific tests that they do is what we call the use test. Okay? The use test does multiple things. It doesn't just do one job. It looks at what the requirement is for whatever job you're doing, and it'll put you and it'll stress you in that environment to ensure you're able to do that job. It's really informal, but they are putting you in a position or a piece of equipment that you will be using or doing during whatever job it is that you're doing. So here we're just talking still respiratory stuff. So PFT and chest X-ray or labs are not required for these guys. Clinical judgment is what they'll use, but if they are not sure, that final decision will be by use test. So just remember that. Okay. And here it's telling you they're going to put the worker in the type of respirator that they're going to be using, and they're going to They're gonna put them through their paces. And that's literally what you do. Okay? It's really informal, it's a real-time check to perform, to see if the worker can perform their job fully cured. Okay? And there at the bottom, so you're gonna get an N95 respirator mask or HEPA filter surgical mask. And they'll fit you for that once you get to your position. Here's some pros. If yes on difficulty with the closed spaces, do a use test. That just means that you don't necessarily mean that you're claustrophobic, but that means that you really should put someone in whatever equipment, location, piece of equipment, mask that may be causing them the problem, to see if they're actually able to do the job while they're in that situation. That's all that means. Okay. And there at the bottom it says gold standards and use test for that. Okay, hearing conservation. Greater than 85 decibels, 8 hours, time weighted average. Okay. This means that if an employee is exposed to the average noise level, right, above 85 decibels over an 8-hour workday, the employer must take action. That's what that statement means. Time-weighted average means it accounts for the varying noise levels throughout the shift average over those 8 hours. So it's not just one moment in time, it's the moment that's cumulative throughout the time. And then the 140 decibels is the bigger one that more so counts for us, because that's the maximum sound pressure or level that a person can safely be exposed to. Okay? Ever so briefly. Ever so briefly. And here it's got, here it's got the examples of gunfire and explosion. It's the highest level allowed instantaneously. That may cause a problem. There is no average, so there's no TWA there. Okay. Instantaneous, it may cause you harm as it happens. And there at the bottom it tells you you're going to get issued hearing protection. Every person. You get your initial and your annual audiograms, hearing protection's fitted and issued. Right? They fit you in an orange one, a green one, a brown, whatever fits your ears according to them. Right? To help you not totally lose your hearing depending upon what you do. Recommendations try to decrease the noise if at all possible, which for us it really isn't, and try to educate you. And make sure you wear your earplugs when you're out doing those kind of things. We're also in vision conservation, initial and annual evaluation for your eyes, and all this stuff goes into doors, they'll review that. You get vision protection when you go out, right? Tell you make sure you wear your vision protection stuff when you're out doing things, especially on the range. This is a big one that most folks don't realize that they can do. It's reproductive surveillance. Alright? So depending upon what job you're doing, that may be hazardous either to your reproduction or if you're pregnant, exposure to pregnancy. Okay? So these guys can come and they can evaluate that area where you're in and they can make recommendations to your command. They can either pull you out of the section or they can adjust it. That's where, remember that little upside down hierarchy of things that we can do, like engineering, substitution, and all that. That's where this comes in. If you are being exposed to something, they're going to figure out what can they do for you so that they can keep you safe within that work environment. sometimes when you're pregnant, there's not much that they can do other than remove you from that section and put you somewhere else until after you deliver. Here's kind of the workup that they'll do for you. They look at your occupational history, reproductive history. Now, this is voluntary. This is voluntary. You don't have to do this if you don't want to. This becomes very sensitive for some people. So if you choose not to, it's your choice. Okay? But they'll usually ask if they do come and evaluate all the workers if there's any changes in sexual behaviors, any changes in their function or libido, if they have any known fertility issues, and then they'll try to narrow down whether it is or it is not a problem. With females, they can ask, menstrual cycle irregularities, miscarriages, or any complications with pregnancies, whether it be in the past or while you've been in that actually hazardous job that they're evaluating at the present moment in time. Okay. For men, it's more about the sperm count, okay, testicular pain, erectile dysfunction. Here's some reproductive workplace hazards, like blood pathogens. We talked about that for, say, providers, nurses, EMTs, paramedics, airborne infectious diseases. Right? We don't know who's walking in the door to come see you. It may be an infectious disease, and they're not wearing any kind of mask, right? And then you have a bunch of physical hazards there. That vibration is a big one that we don't usually pay attention to. Right? And it says 5 to 10 hertz to be transmitted through the abdomen to the uterus. So anything between 5 to 10 where you're actually holding on to something can really cause spontaneous abortions, preterm labor, or low birth weight babies. So something that a lot of times we kind of sort of forget. Okay? And who's kind of exposed to that stuff? That'd be those flight medics and those flight surgeons, right? The folks that do aircraft maintenance, folks that do heavy equipment operations. So you have to kind of put this into perspective when you're looking at it. Reproductive workplace hazards, exposure to the following substances have also been associated with spontaneous abortions. Right? If you work somewhere where there's lead, right? If you work in some place with batteries or paint, right? It's an occupational hazard. Ethylene oxide is used for cleaning medical and sterilizing medical equipment. Bad stuff. Ionizing radiation, waste anesthetic gases. You guys should be spending some time with the anesthesia department when you go to phase 2. Some of those gases that are coming either out of the patient or not being captured appropriately by the anesthesia machine, you guys may be exposed to. So keep that in mind. All right, let's go ahead and take a break. This section here basically is protection, reproductive protection referrals. You need to identify the risk, like the exposure risk, especially if it's organic or biotoxic. Right? So you got to look at that job description. You got to assess the workers' reproductivity status, right? More so for females, because they're the ones that actually carry the baby. You gotta find out whether the individual wants to conceive or not wants to conceive. Find out if they're pregnant or not pregnant. You want to find out if they're breastfeeding or not breastfeeding. All these things play into that productive deferral. So what would happen is they would come, they would assess, right? Occupational health would come and assess your situation, find out all those questions, and then they would talk to your supervisors or personnel authorities who can make those decisions. They'll check with the workers, supervisor and AO as to the exposure, and that hierarchy of controls is what they're gonna try to do, right? If they can eliminate it, then they'll probably try to move you someplace else, okay? Until you're able to come back. That's usually what ends up happening. If they can't eliminate the problem, or substitute it in some way that you'll still be safe. So here, PAs, off health travels to work sites to evaluate overall health situation with and OSHA requirements. And you do follow some OSHA standards, but the hierarchy controls is really what we're going to try to do when we go to wherever place we go to figure out what the problem is. Right? So really, this stuff is dependent on your job, right? Your occupation, and it's dependent on the environment that you're working in. And then you can apply some of those hierarchy of controls all the way to the bottom there for PPE, which is the least effective. Anybody have any questions? No? We'll get into a couple of these and then we'll cut it up so that you guys can have some of those before you go to our 12 o'clock. Okay. So medical threat assessments. If you are an MSC officer, this stuff should be right up your alley for the most part. Here's some criminal learning objectives. The deal with this one is we're really going to talk about force self-protection. Okay. Here's a whole bunch of objectives. Describe driving force, force self-protection. Okay. So here's a whole bunch of risks. You have to take all these things into account, right? Travel is an occupational hazard that we have. It is part of what we do, right? But you, as the provider, are going to have to take some of these hazards and you're going to have to figure out how to mitigate them. Okay? Whether it be exposure to arthropods, whether it be exposure to water safety hazards, whether it be exposure to natural disasters. Okay? We're still going to have to worry and concern ourselves with those kind of risks when we're trying to think about how to mitigate them. This is straight from the military medicine textbook. The composite of all ongoing or potential enemy actions and environmental conditions that will reduce combat effectiveness through wounding, injury, causing disease, or performance degradation. That's your medical threat. And within those words, it's going to be up to you to figure out how you can countermeasure those effects. What kind of preventive medicine you can do to not have those problems. A lot of these concepts are basically for deployment and non-deployment issues. These can even be applied to anyone coming to your clinic because they're going to travel to some place that has some endemic issues in it. Okay? So you can look at it a couple of different ways, not just a deployment. So force self-protection refers to a bunch of policy strategies and practices designed to maintain and improve the health of military personnel, ensuring that we are physically and mentally fit to operate and complete our missions. That's where we got that number 92%. That's what your goal is for medical readiness once you get to wherever you're going to go, wherever unit you're going to go to. Right? And part of that is you adding preventive measures and or reactive measures or treatments to preserve the combat effectiveness wherever you are. Whether it be before you go and take off or whether after you're gone. Okay, so here's some risks. Identifying threats depends on only basic information. You're going to have to go to some meetings. Some places don't have medical service corps officers. You, provider, PA, will be that medical service corps officer. So you will be going to some of these meetings. You will be helping in making some of these medical claims, even though that's not your job. It is now. Okay? So understanding the who, what, where, and when is going to assist you in being able to help them get information that they're going to need to be able to make good decisions. To help come up with a strategy on what you need to do. Okay? Because if you can accurately identify a threat, you can generally manage to mitigate that threat. And if you're able to mitigate the threat, that helps your personnel stay safe. Right? And a lot of that's based on your population, based on where you're going to go. Right? Combat versus humanitarian, right? In combat, you're more concerned with being attacked versus humanitarian, you're more concerned with disease processes, status post. You're finding people that haven't been killed and trying to keep them alive or revive them. And by all means, especially for infectious disease, location, right? Person factors, number of total population, the area operating. And you'll get a lot of this stuff when you go to whatever meeting you're going to go to, depending on where you're going to end up pointing to. The demography, the health status, psychosocial issues, the training. There for psychosocial, you have asynchronosis. That's just a fancy word for saying jet lag. Okay? And most of the time we're going across the pond or long flights, so jet lag does become an issue. You may want to carry some sleeping pills to allow them to sleep on the plane, so when they get there, they can kind of be a little bit rested, so that may help a little bit. Okay, some of the training that you do can also get you prepped for going to wherever you're going to go, and your activity. Okay, really dependent. Is it operational? Is it occupational? Is it recreational? There's place factors. Right? Location. Right? That's really going to tell you whether or not you're going to need chemoprophylaxis or you can do anything else, medical-wise. Climate stability, terrain, desert, mountain, rainforest, biomass. Here's a flora or fauna, but that really refers to any organic material that comes from plants, animals, or microorganisms that can be used as some kind of fuel source. There's a lot of places overseas that take a lot of this stuff, and that's what they use for fuel. Sometimes when we're using bodily evacuation stuff for that, as it burns, you may be inhaling that. So things to keep in mind, because some of the places over there don't have water treatment sewer plants. So keep that in mind. Okay, time factors. Year is going to be long, it's going to be short. Are you going during the height of the mosquito season? Climate, time of day, right? Day mosquito fighters versus night mosquito fighters, duration, how long you going for. Going straight, you're going to be able to come back and go on leave because you're going for such a long period of time. These are all things that you're going to have to factor in about this. Now these are kind of important. When we talk about medical information, we actually talk about the raw or factual data. That stuff has not been vetted. That stuff has not been analyzed to a point that I can use it strategically. Okay. Medical intelligence, on the other hand, refers to analyze, process medical information. Okay. That becomes actionable. Right? Raw stuff, I'm not sure if it's real. I'm sure if it's true. It's kind of difficult to say that I can action on advice, medical intelligence. It's more actionable, it's been analyzed and processed. It's good information that you can use for strategic planning. Sources of medical intelligence. So NCMI means National Center for Medical Intelligence. National Center for Medical Intelligence. That is where you will probably go to get most of your medical intelligence when you're gonna go someplace. That website there at the bottom, if you actually have your appropriate credentials, go ahead and go to it. If you have your CAT card, put it in and it'll let you in. That's a great site. I like that site. Very informative. Okay. Especially if you're trying to figure out wherever it is you're going, what's going on in that area. Okay. These guys are part of the U.S. government. Okay. And they gather, analyze, and disseminate medical intelligence. That's literally their job. That's all they do. They support the national defense security. That's part of what they do. They help public health efforts for us, for the military. They monitor and assess any of those health threats that they find. They monitor and keep those trends to find out if it's getting better or worse, to see if it's going to affect us. The other thing that they also do is they monitor the borders to find out if there's any trends along the border areas. And that's a big deal between Texas and New Mexico and Central America. Now, these guys go through everything. When I say everything, I mean they go through medical literature, they go through reference material from the World Health Organization, from the CDC, from the ministries of public health is what most countries have that's comparable to our CDC. Right? They go through all that information. They translate foreign news to English to use as part of the information that we use for medical intelligence. Okay? And they cram it all together. And that's how they come up with their assessments. The tactical source of intelligence isn't our responsibility. That is all S2, G2, or J2. We don't concern ourselves with any of those tactical sources. We just concern ourselves with medical intelligence. This is their little page here. If you go to that website that was on that last slide, it'll take you to this page, and you can click on there for any infectious diseases. Another tab will pop up for that, and you can click on there. Just make sure that you have allowable pop-ups, because otherwise it won't work. Okay. So this is pretty important, because this is what's going to help you figure out what your risk factors really going to be. Okay. So the primary role of NCMI is to identify, analyze, and assess health risks, right? To deal with NCMI is that they are identifying everything without countermeasures and without preventive measures. Okay? So when they analyze it, it is the worst case scenario. It is the worst case scenario. Okay? That's your left side there. Okay? They'll assess all the hazards and all the risks, all the trends. They'll do it all. No countermeasures. So worst case scenario, you saw some of those numbers when we did disease of military importance, when we looked at malaria, when we looked at dengue. It said operational impact 11 to 50%. That's part of this. Right? That's part of this. Now what your job is going to be is going to take that 11 to 50% analysis that they did and add in your mitigation factors, your preventive measure factors, to to decrease that operational risk. That's what your job is going to be as a medical officer at whatever unit you're going to be when you deploy. Now, do not look to NCMI for any approved or authorized prophylaxis. That all comes from pilot, right? Comes from the surgeon. Do not look at them for recommendations of medical treatments or protocols. That comes from higher or your medical knowledge on how to treat diseases, right? And do not look at them for medical policy and doctrine. So folks that do medical policy and doctrine take this information and use some of it to come up with some of that policy and doctrine based on what they find. Okay? All right, so these are the assumptions that they go under. Barring, if you see the bottom there, it says no countermeasures. You must determine residual risk to your population in the setting of countermeasures. All right. So when they make their worst case scenario, they're assuming that you have a healthy force, right? They're assuming that there's no immunity to most tropical diseases to us. So again, worst case scenario. So this bottom piece here, with no countermeasures, tells you that they're going to give you the worst case scenario, and you will have to take it depending upon where you're going to go in the world and add your countermeasures or your preventive health measures to decrease that overall risk. That's all this is saying. Okay? That's all this slide is trying to tell you. NCMI does not use countermeasures for their analysis. That is going to be up to you. Okay? Because remember, that countermeasure or the preventive health analysis that you're going to add to this is dependent upon where you go, how many people are going, what time of year you're going, is there any ability to give prophylaxis and vaccines for that, any of the stuff that's happening in that area. There's a lot of what ifs. So it's going to be up to you to figure out what that what if is going to be. So you guys remember attack rates, right? The proportion, right? In the last slide deck, the 2 slide decks that we covered, the proportion of population that becomes ill over a specific time period, right? Versus severity, which is the seriousness of the illness that's caused by the disease. So what's going to happen is you're going to take the 3 of these, attack rates, severity, and operational impact, and that's going to give you the expression of operational impact. That's all that is. Okay? Those are just crucial factors that are going to help the military, national security, and other health organizations understand and be able to respond to whatever's happening, depending on where you go. Okay? That's all this means. So, if you do remember the slides from military diseases of importance, right, on some of them you saw right here, it points out potentially as high as 11 to 50%. This is where this stuff came from. It came from the attack rates that they developed. And here it's telling you for each disease that NCMI assesses, an estimate has been made on the worst case monthly rate. NCMI does the worst case. Right? And then in disease dynamics, we did a little bit of math. And the math that we did is where these numbers came up so that you can put them under diseases of military importance. And if I remember correctly, dengue was 11 to 50%. Okay, so that's where that math came from. When we talk about severity, we have 4 things that we use: mild, less than 72 hours, sick, or limited duty, right? No hospitalization. Moderate, 1 to 7 days, inpatient supportive care, followed by return to duty. For the first 2, you're still good, right? when you get to severe, greater than 7 days hospitalization or convalescent, you gotta be evacuated. And then for very severe, same deal, you gotta be evacuated, right? That's ICU requirement, so. Those are the descriptions that we use for severity. Okay, and severity really covers the morbidity and the mortality of whatever disease we're talking about during that time period. Okay. Now this is what they use to figure out, and CMI uses to figure out those numbers that they came up with. Right? So between the numbers that they came up with, we'll say, right, dengue was 11 to 50%. We'll say a lot of you guys are going to end up being severe, right? So we're going to have to get rid of them. They're going to have to be evac'd. Okay, where they intersect. Okay, for severe and potential is high risk. Right? So that would put those folks, expected disease level in their troops would be at high risk. What that really means is that without any countermeasures, you have a high-risk population right now. That means that you're going to have to figure out what you need to do to try to bring those numbers down. So this is the overall country risk. This is how we define these guys. Potential impact for mission effectiveness is based on very high risk, medium risk, low risk. And so if we're talking about very high risk, we're talking worst in the world for that disease process to include seriously jeopardizing the health of the force. Versus high risk where you're seriously jeopardizing the mission and effectiveness of the health of the force. Vice intermediate, where you're just adversely affecting or impacting the mission and effectiveness, and then low risk, unlikely to have any significant adverse impact. These are all means of descriptions of deployments and things that you're going to have to start looking at to figure out how can I mitigate some of these risks. Let's stop here and pick this up.